Hi everyone, we are from Group 1 going to presenting about the influenza virus. Influenza virus is from the family of Orthomyxoviridae and it has three genera which is influenza A, B and C. It is a single-stranded negative sense RNA with a segmented genome. In terms of its structure, it is an enveloped filamentous and spherical virus with a diameter of 120 nanometer. Influenza virus have two important glycoproteins on its surface which is heme agglutinin and neuraminidase. It also have two matrix proteins which is M1 and M2. Influenza virus can be transmitted through respiratory droplets and vomits. It can affect all age groups, especially infant, elders, pregnant women, and immunocompromised individuals. Outbreaks caused by influenza are Spanish flu, Asian flu, Hong Kong flu, and also H1N1 pandemic. Among all these outbreaks, Spanish flu, which was occurred in 1918, was the deadliest.
Influenza or the flu spreads primarily through respiratory droplets produced by coughing, sneezing, or even speaking. When these droplets are inhaled or transferred to the nose, mouth, or eyes via contaminated surfaces, the virus reaches the mucosal surfaces of the respiratory tract. When inside, the influenza virus first encounters the mucus layer that lines the airways. The mucus produced by globular cells traps pathogens and works alongside with ciliated epithelial cells to expel them. However, the virus have the strategy to bypass this defense. The hemagglutinin HA protein or its surface binds to the sialic acid containing receptors on epithelial cells in the upper and lower respiratory tract, including the trachea, bronchi, and bronchioles. This binding allows the virus to enter the host cell through receptor-mediated endocytosis. Inside the cell, the virus hijacks the host machinery to replicate, damaging the epithelial cells in the process. Destruction of globule and ciliated cells disrupt mucus production and clearance, exposing the respiratory tract to further irritation and secondary infections. This initial infection is the key step for the influenza virus to establish itself and spread further.
Influenza viruses are very selective about the cells they infect, a process called cellular tropism. This is determined by the hemagglutinin or HA protein, which binds to the salicylic acid receptor on the host cells. Neuraminidase or NA protein also complements the binding specificity of HA by the cleaving salicylic acids, preventing reattachment and allowing new virus particles to spread efficiently. Human flu viruses target alpha-2,6-linked salicylic acids, abundant in the respiratory tract. Avian flu viruses prefer alpha-2,3-linked salicylic acids at gastrointestinal tract, which common in birds. While humans do have alpha-2,3 receptors deep in the lungs, they are harder to access, limiting avian flu infections. Swine influenza viruses are unique. Pigs have both alpha-2,3 and alpha-2,6 receptors, allowing them to be infected by both human and avian flu strains. This dual binding ability makes pigs ideal hosts for missing strains, like the resortment that led to the 2009 H1N1 pandemic.
Influenza viruses are classified into four main types, which is influenza A, B, C, and D. Among these, influenza A and B are the culprits behind seasonal flu outbreaks. Let's dive into each of the influenza. So the first one, influenza A, is a shapeshifter with subtypes like H1N1 and H3N2. This is due to its hemagglutinin and neuraminidase proteins. While influenza B, it sticks to two lineage, which is Victoria and Yamagata, and influenza B can cause seasonal illnesses. Next is the influenza C, which leads to mild respiratory system. For influenza D, it prefers cattle and not humans. Knowing these types help us create vaccine and stop the flu in its tracks.
When influenza viruses infect cells, they trigger cytopathic effect. This refers to the visible structural changes in cells that are caused by the virus. For example, infected chicken cell culture with influenza viruses shows some swelling cells and vacuole formation compared to the uninfected chicken cells. Meanwhile, infected duck cell culture shows cells surrounding and detaching from surface. Apoptosis or programmed cell death, where cells undergo nuclear membrane breakdown, chromatin condensation, and loss of membrane integrity. The virus activates this apoptotic pathway by disrupting the mitochondrial membranes through the BCL2-associated death promoter (BAD) protein, a regulator of cell death. This leads to the lung tissue damage, a hallmark of influenza pathogenesis. As epithelial cells die, they release pro-inflammatory cytokines and chemokines like interleukin 6, interleukin 1 beta, tumor necrosis factor alpha, interferon gamma-induced protein 10, and more. These attract immune cells such as neutrophils and macrophage, which amplify the inflammatory response. While this aims to control the infection, it damages the surrounding tissues, led to the pulmonary infection, acute lung injury. High levels of these cytokines and chemokines also contribute to the symptoms like coughing, difficulty breathing, and nasal congestion.
Host immune response can be divided into two types which is innate immune response and adaptive immune response. Innate immune response will be activated when PRR on the host cell detect pump on the virus. Detection of pump will release type 1 interferon that activate and direct natural killer cells and macrophages to the site of infections. Other than that, interleukins and tumor necrosis factor alpha will also be released to produce immune cells. Failure of innate immune response to destroy the virus will activate adaptive immune response. In adaptive immune response, T cell and B cells are the hero. T cells, there are two types of T cells, which is helper T cell and cytotoxic T cell. Helper T cell will be differentiated into two subsets, which is Th1 that will activate the cell-mediated immune response and Th2 which will activate the humoral immune response. Activated B cells will neutralize heme agglutinin and neuraminidase, while the antibodies will prevent the virus from attaching to the host cell. The role of interferons in host immune response is to signal neighboring cells to activate antiviral defense, while the role of T cells, which is helper T cell, is to coordinate with other immune cells to fight the virus, while cytotoxic T cell to directly attack the infected cells. For antibody, it will recognize, bind, and mark the virus to be destructed by the immune cells.
Influenza viruses have evolved intricate ways to outsmart our immune system. Through antigenic drift, the virus makes small genetic changes, evading existing immunity. Antigenic shift, on the other hand, creates entirely new subtypes, leading to pandemics like H1N1 in 2009. By producing NS1 proteins, the virus blocks interferon signals, disabling our body frontline defense. It also downregulates MHC molecules, weakening the adaptive immune response. Influenza damages cilia in the respiratory tract, impairing mucus clearance and paving the way for secondary infection. Filamentous particles help the virus to avoid neutralization, which ensuring its survival. Rapid replication increases mutation, enabling the virus to adapt to immune pressures and treatments. Decoding these evasion tactics helps scientists design better vaccine and therapies to fight influenza.
Influenza, a viral respiratory illness, typically begins with symptoms around 2 days after infection. This includes sudden fever, dry cough, sore throat, body and muscle aches, severe fatigue, and joint pain. The influenza virus primarily infects epithelial cells in the respiratory tract, causing cell death and damaging the respiratory epithelium. This leads to symptoms like coughing and sore throat. The body's immune response plays a dual role. While it works to clear the virus, it also contributes to the symptoms. Infected and immune cells release pro-inflammatory cytokines, essential for combating the virus, but excessive production can lead to systemic effects such as fatigue, fever, and muscle aches. Those at higher risk, such as pregnant women, children under 5, the elderly, and individuals with chronic or immunosuppressive conditions, are more vulnerable to severe complications. In these cases, inflammation triggered by the immune response can amplify damage, causing life-threatening outcomes, as the fragile respiratory layer is breached, intensifying both local and systemic inflammation.
Influenza treatment combines managing symptoms, antiviral drugs, and preventive measures like vaccination. Over-the-counter medication help reduce fever, pain, and nasal congestion. Supportive care such as hydration, rest, and using humidifier is essential. Together, these steps reduce severity, speed recovery, and prevent complications. Antiviral drugs are crucial in treating influenza. The most common are neuraminidase inhibitors, which can be taken orally or inhaled. These stop the virus from spreading, but most effective within 48 hours of symptoms onset. Newer drugs block the virus replication and are effective against resistant strain. This treatment help reduce the risk of severe illness, especially for the high-risk group. Vaccination is the best way to prevent influenza and its complications. Types include inactivated vaccine for almost everyone, live-attenuated nasal spray for healthy individuals, and recombinant vaccine for those with severe allergies. Vaccines not only prevent infections but also reduce the severity of symptoms and hospitalization. Annual vaccination is critical due to the virus' constant mutation. Though influenza is usually an acute illness, its long-term effect can be significant. Post-influenza fatigue often lasts weeks, and secondary infections like pneumonia can worsen chronic conditions such as asthma or heart disease. Rare complications including Reye syndromes in children and Guillain-Barré syndromes highlight the potential for severe outcomes. Globally, influenza causes major economic strain with annual costs in US exceeding $11 billion due to hospitalization, outpatient visits, and lost productivity. Vulnerable population including the elderly and those in low-income countries face risks. Past pandemic like the 1918 Spanish flu reveals the potential of influenza to overwhelm healthcare systems and cause millions of deaths. WHO leads global efforts through the Global Influenza Influenza Surveillance and Response System, which monitors viruses and guides vaccines updates. Public health strategies focus on increasing vaccination rates, stockpiling antivirals, and promote hygiene. These aim to reduce the burden of seasonal influenza and prevent future pandemics.